Thank you for staying with us. Despite being preventable and treatable, malaria continues to have a devastating impact on people's health and livelihoods around the world. Malaria is a mosquito-borne disease that mostly spreads to people through the bites of some infected female Anopheles mosquitoes. According to the World Health Organization, Nigeria contributes 27% to the global malaria burden. The organization has also set a target to reduce global malaria incidence and mortality rates by at least 90% by 2030. Although efforts are being made to create a world free of malaria by 2030, would Nigeria be able to meet up to achieving this goal? Joining us in the studio to discuss this is a public health consultant, Tui Bawodu. Good morning.
Good morning.
Thank you for joining us.
Good morning. Thank you.
Now, just yesterday, we got a report that the Federal Capital Territory did not meet up with WHO target for 2022. WHO had targeted 80% to addressing this matter of malaria, but they were only able to achieve 66%. And they list out some of the challenges they face, talking about parents, accessibility, funding, and all of it. And it seems like Nigeria has a reputation of not meeting targets for anything, basically.
Anything positive.
Positive. Well, unfortunately, from your observation, why are these challenges really insurmountable, or what really is the missing link with regards to we meeting our targets?
Thank you very much. This malaria scourge is actually an embarrassment. Mm-hmm. It's a shame to a country. Gradually, malaria is now becoming an African-only problem. How do I mean? 241 million people cases of malaria, 619,000 deaths, 95% of that in Africa. And Nigeria is proud to be, the main contributor, 27% of global burden and deaths in malaria. So gradually, the whole of the world is moving away. Even the Asia, they're moving away. The thing is now being confined to Africa, and it calls for a serious reflection. Let me actually be graphic about it a bit. What that means is that for instance, every minute, you lose a child under 5 to malaria. So that's 60 deaths, in a whole lot. The malaria deaths in Nigeria is like having 2 Boeing 747 fully loaded crashing every day. Let's make this Boeing 737 Boeing fully loaded crashing daily. So in essence, we're seeing hemorrhaging women that are supposed to give birth are dying, essentially. Children that are supposed to drive the country forward are also dying. And with fold our arms, you cannot actually eradicate just one thing. And malaria could be very easy, like you rightly pointed out, preventable and treatable. Now, the global strategy, technical strategy says that, okay, you know what? In 2030, this was fashioned in 2015. So in 2030, we're going to reduce malaria incidence by 90%. We're going to scale up. We're going to put investment. We're going to move everything inside. We're going to move to eradication of malaria. And then here we are. We look at all the instruments we need to use to make that happen. Now, one of the instruments we use is actually, say, okay, we're deploying insecticide-treated nets. Look at Nigeria. Just about 56% of the household has insecticide-treated net. They have it, they won't use it. Having it is a different thing, using it another thing. So like half of them will now use it. Now, you look at the children, IPT, the intermediate treatment, preventive treatment of malaria in pregnancy, just like 30% of women are actually taking the 3 doses, okay? They are not getting it.
Is it not available?
No. It's available. You get to understand it. Now, the platform to get it in terms of, scaling up health system, like primary health care, PHC.
Right.
30,000, only 3,000 are working. Have light, have water, have human resources. So the 3,000 out of 30,000. So, of course, how do you now deliver those interventions we're talking about? If it cannot be delivered in primary health care center, the closest to the people, the largest number that can happen. And secondly, the other place of intervention is actually even the private health system. Okay, we've seen the partnership between private health system in fighting some diseases like tuberculosis and HIV in the past. We even see that engagement of private health system, even in malaria. But all those things have come down now. There's no fund, there's no human resources, the government will is not just there. The thing has actually been ceded to who? To partners to donate for that program. And then, of course, when you donate and the money is not being used properly, we have those challenges. So, I mean, it stands to reason that what we can do is actually to sit down and keep discussing why malaria is a problem to us. Because we are losing about as much as $1.1 billion every year on malaria. Absenteeism. In fact, for me, I tend to really relate some depth of our thinking to malaria affectation, either pregnancy or at early stage. Because when you look at this way some of us reason, sometimes you wonder, what is wrong with the brain? And I keep looking at malaria as the dominant factor that is affecting nutrition. And then you have the cross-cutting issues. Malnutrition is a big issue, here, when you are malnourished, your brain is malnourished. Malaria easily comes in and then you do the cleanup, in terms of your thinking. So malaria is an embarrassment. And it is the right time that we sit down, honestly, and look at one thing we want to eradicate in this country. Are we going to eradicate even ordinary tetanus from every part of this country, or we're going to eradicate malaria? So honestly, simple processes, malaria, one parasite, two animals, or interacting in an environment. That's all. The vector control is having a problem. We're having challenges with resistance to drugs. Okay? Because everybody swallows drugs and they don't even use it properly. The molecule we're having now is about the only saving molecule. Once we lose it, what do we do? Research is done abroad. Our own malaria research is shortchanged by lack of finance and human resources to carry out those. So again, what do we do? Let's go local. Let's go local.
How do you mean?
Okay, primary healthcare centers, community development associations, faith-based organizations, specific NGOs, to look at, for instance, the CDS can help us look at the cleanliness of the gutter and all those things, and then also do campaigns about malaria intervention, help us to distribute ITNs, insecticide treated nets, to household, and ensure, teaching to utilize those things, okay? Now, that would be a wonderful thing to engage them. It's not, if you want to distribute that kind of thing as part of your palliative, wonderful, okay? So not just... So,
we have to bring palliative matter.
So look at the CDAs, look at faith-based organizations. You have churches, you have mosques, you have all this Guru Maharaji, everybody, okay? Help them, tell them that, listen, malaria is not helping us. It's not even helping people, the health of your congregation. Help us campaign for against malaria. Help us distribute this thing. Ensure your pregnant people have access to those drugs. So I mean, we can do a lot at that local level. The campaign must be strengthened. We must strengthen our communication and improve the strategy of communication. That's the cheapest thing we can do. Again, engage people to do those campaign and communication for you. It's a strategic, targeted thing. And we saw at the end of in the other time, the involvement of some big industries, big companies in this malaria fight. Tell them, if malaria is decimating the population, you won't get great people to work in your companies. It has an economic impact. So we must be able to tie together this communication. If you don't do it...
All right. The issue of malaria has been with us all the while, and one expects that we should have known, like you were talking about going local. If we have to go domestic as to like homegrown solutions, we should have been giving the solution of malaria issues to the world. But unfortunately, it is the other way around, because research and funding and all of that has to go in, and especially when you're talking about the orthodoxy of malaria processes and all of that, scientific method and so on. But now we understand there's a vaccine, for anti-malaria vaccine. It's been tested in some countries, and one would say, okay, if we couldn't prevent malaria from the perspective of our environment and nets and so on, and habits and exposure, then we should have been able to prevent from the area of vaccination, where the moment, like the other killer disease, you vaccinate against them. The moment you vaccinate against malaria, then for life, or at least for a period of so many years, you're supposed to be free. But we're not seeing that vaccination thing. How accessible are malaria vaccines now to countries around the world? We know that it's still coming on board gradually.
Well, look, just don't bother yourself about the countries around the world. Talk about Africa. Talk about Nigeria. Malaria is becoming an exclusive disease of Africa, 95%. And Nigeria is contributing 27% of all the global number and death. Now, look at another disaster. Gavi came up and developed malaria vaccine. They already actually deployed malaria vaccines. Nigeria is the country with the highest number of malaria burden. Okay, now Gavi said, write application, fill this form so that you can enjoy the 18 million vaccine that is going to be deployed between 2022 and 2025 or so. Nigeria failed to fill in the application. They missed it. So you ask yourself, you can, please, I'm not a ministry person.
I'm just wondering why.
They missed it. They couldn't apply. Now they had to apply. They're thinking about putting them in maybe sometimes in May next year to put them in that. So you have expected that Nigeria will be the first country
Exactly.
to put the application. Give us the vaccines. Let's put it under 5 children so that we won't be losing them. Okay, but they failed to. So again, you know, the mentality of everybody is that if there's no money I can take from this thing, then I'm not interested. And that's why, of course, we felt that the best way we can really, reduce poverty is to distribute money. You understand? That's an interesting issue. So, but again, it is what it is. Let's just leave it at that. But now, the vaccines are there. We are not going to enjoy the vaccines until maybe next year, hopefully. So then, how do we now navigate that kind of thing? Okay, we stay with what we have for now. And then when you come to research, you see, you see your health workers existing in your country, not just health workers. Look at the mess that the bank is. The IT guys are all gone. The bank is at the end of the mess. Even your call, you're just dropping anyhow now. And we want to be the leading economy in a nation. And we're not talking about health, we're not talking about education, we're not talking about human resources. We're not addressing, at least we can save close to $1 billion if we fight this malaria thing, well. Let us eradicate one thing. Let us eradicate one thing. We're not that unintelligent, okay? So the vaccines, Mike, is not coming until the best time is May next year.
But have we filled the forms now?
It's already the question to the ministry. they know what to do.
Well, 2030 is less than
7 years. 6 years from now.
Yes. So on the trajectory that we're on, are we going to meet up, or if we do not do anything, paint us a picture of what the situation could be?
Now, 2030, 6 years from now on, what figure, where are we now? 27%. We're still, crashing 2 Boeing daily, fully loaded 2 Boeing daily from malaria deaths. We have not actually scaled up intervention, and I'm not seeing any critical thing to scale up those interventions. The primary healthcare that should actually deliver most of those interventions, we're just having 30,000 out of 30,000 working, okay? So, that's a lot of money. The human resources that we need to get to do that is not happening. Now, the malaria medication, we're having resistance, increasing resistance. And of course, the Naira balancing or whatever is affecting the critical active pharmaceutical ingredients that you need to bring into the country to produce those things. So now, if we don't do anything, this country will probably going to increase. Because the hand of the clock has already moved about maybe 1%. We used to be like 28% or 30%. We're now 27%. After since 2015, that's a long time ago. So hopefully, if we keep doing something, probably we'll get to like 15% and then keep reducing. But if we don't do anything, we're going to notch up. I'll go back to a 30% or even 40%. Most of the resistant strain of the malaria will reside in the country, and then the death of the children will come. The severe malaria will be seen here, and then we'll still be running around trying to figure in the next 6 years started to shout about malaria and how to prevent it, how to take care of it. So for us, is to look at a simple thing that is doable, that can be scalable, you know, and then I keep repeating strategic communication. I keep repeating, go local, you know, touch every organization. It's not just noise on TV and media, but again, it's noise about engaging your community development associations and groups, engaging women groups, engaging, you know, family groups. I mean, they're there. There are women associations all over the country, engaging your faith-based organizations and NGOs, and then see how to look at the tiny one they can do in trying to reduce the scourge of malaria, which is a great shame and embarrassment to a country of Nigeria that is bugaing all over the place.
Well, talking about this communication and engagement, there's nothing as important as that, because when people become enlightened, they at least know what to do and how to go about these things. I recall as a young boy where we used to have agri extension workers, health extension workers, these officials, 2, 3 sometimes, will come to the house to ask questions or talk about certain things. We don't have those anymore. Is it that those extension workers are not being trained anymore, or everybody wants to become a doctor and then jackpot as the case may be? But we still expect that we should have some of those persons who should be able to engage, moving from family to family, door to door, engaging people.
Everybody wants to become a skit maker, not doctors. to make skits and then ask funny. That's what everybody tries to do, not doctors.
And get endorsed.
And get endorsed. And then become a social influencer. Let them influence malaria intervention now. We want them to, you know, it's nice. You can be influencer, but influence malaria intervention. It's going to help all of us. I think we need to actually sit down. Let me tell you what. If local governments can be made responsible and functioning, we might achieve a lot. And then we sincerely give them some tasks to do, because we should not actually always look at top there, the federal government must do this and that. But there are lots of things that can happen at the local level, you know, with the cooperation of the people and engagement of the people. No, I would drop that on the laps of the local government people to have a synchrony of what is possible. Yes, the primary health care center, each of the states will have their own primary health care, agency, which can actually work with the local government as it is and look at their data and discuss continuously. We shouldn't be tired. But again, you know, a poverty mindset is not just poverty of the pocket. A poverty mindset tends to drill a lot of things. Everybody is just focused on where is the money? That is what everybody is focused on. It's nice to focus on money, but again, you need help to spend the money. So now, we're not even seeing those community health workers coming to your house, looking at your gutters, checking your, those days, you know, we need to stop pots. They look at it that, oh, where's Tanwiji, those small larvae, and tell you that these are the things that cause malaria. The awareness was heightened. Now we're having a lot of social media spaces for people to interact. Still, we're not talking about critical issues that are essential to us. So what I expect is actually to create, whether you call Twitter space or what's the name of that trend? Is it trend or
Trends?
Trends. Whatever space, create it and discuss this thing. Let us be able to have an input of social influencer, skit makers, everybody into the malaria discussion, into health discussion, not just malaria discussion. So I think we can gradually gain traction. And for us, what we learned in primary school those days used to be simple hygiene rules, what is the threats in our environment. We may have to really design the simple pictorial things to teach the student at the age of 3 years that, listen, this is malaria, this is how to prevent it. You'll be able to inculcate that gradually into them and you understand what it means for malaria. And then let us understand the fact that malaria is actually hitting our thinking process and development of our brains. I mean, a child cannot have cerebral malaria and be normal again. It's very tough. It's very tough.
2 questions that I want to ask quickly. It has to do with, you've been speaking about resistance, malaria resistance, and I'm wondering why we are having that. And then you talked about we having primary health care about 30,000, but just 3,000
10%.
is functional. That's a huge number that is not functioning, about 27,000 of them. How do we begin to resolve these issues with regards to the 27,000? I recall that former President Muhammadu Buhari once promised 10,000 more primary health care at some point, but we don't know what happened with regards to that aspect. But for the resistance malaria, what really is the issue?
One, germs are also smart, okay, and that's why you can see them going through different processes to infect human beings. And they also find a way to actually counter the medication you put into them, you put to kill them. Resistance happens, basically from maluse or abnormal use or improper use of the malaria medication, okay? Most of those molecules are given for certain time, dosing, and for a length of period. Once you get a bit better, everybody walks away. And then at the end of the day, you will get the germs adapting to this thing. Secondly, fakery. A lot of fake drugs. We need to step up that surveillance to pick fake drugs. A lot of fake drugs, hawking inside the vehicle, hawking on the streets. Everybody feels like a doctor. Once they say, oh, you have malaria, I'll go and use medicine. And they swallow and they don't swallow properly. So, and then we need to step up. These are key issues in resistance. I don't know. Try. For children, we tend to say, okay, syndromic treatment of malaria. But for adults, say, run a test and confirm that you're having malaria. So we need to strengthen this what I call the protocol for malaria care. I mean, so that we don't get much of the resistance. And then we have to also step up our researches because the germ will get smarter. It used to be chloroquine, it used to be quinine. We abandoned chloroquine since how many years ago? Maybe 2005 or so. Now we're
returning
now we have find a way to return to all these things.
All right.
So at the end of the day, that prevention, that critical prevention and environmental management, the environmental, the climate change is actually contributing.
All right.
And we're seeing malaria even in America, in Florida now.
Okay.
So
we have to leave the conversation here now. We must thank you to Yemi Bawandu, public health consultant, for your time on the program.
Always a pleasure.
Thank you very much for coming.
Right.
Right.
Teach me how to make skits. So.